Welcome again to our presentations. Today we are going to look at the right side of the heart. In the previous sessions we were actually discussing problems of the heart that affect the left side of the heart. We looked at the valves, we looked at the chambers, we looked at the heart muscle. So this session particularly we are going to discuss and show cases that affect the right side of the heart. It's a side of the heart that is mostly neglected by people who do echo, because to start with, the right side of the heart has a very complex structure or anatomy, and usually the images that come from the machine, if you are not skilled, they are not very clear. So you need to be very highly skilled to get the good images from the right side of the heart. Particularly today we are going to look at right heart disease and singling out pulmonary hypertension. Pulmonary hypertension is raised filling pressures on the right side of the heart. It can either be pulmonary arterial hypertension or it can be post-capillary pulmonary hypertension, which is secondary to a problem arising from the left side of the heart. So in this case, we are going to concentrate on causes of pulmonary hypertension that arise from malfunction or dysfunction of the left side of the heart. The anatomy or the structure of the right side of the heart, the right ventricle itself, it is a known fact that the right ventricle is the closest chamber to the chest wall when we are scanning the heart, and it lies on top of the left ventricle. Its main function is usually to pump the blood from the right side of the heart to the lungs, and therefore the right ventricle, when you compare the thickness of the muscle of the left ventricle and the right, you find that the right ventricle has got a thinner muscle because it doesn't have a lot of work. It just has to pump blood to the lungs, as compared to the left ventricle that has to pump blood to the rest of the body. So as I said, it is closest chamber to the chest hole, and it's not structurally engineered to cope up with sudden rise in filling pressures, because it doesn't have enough time and a strong structure to cope with high pressures. Therefore, it is very prone to have a dysfunction once the filling pressures have exceeded its capacity. So as I said earlier on, it has trabeculations. Those are structures that are found in the right ventricular chamber, and this is a chamber of the heart that is difficult to image. But usually when there's a problem, when there's a dysfunction and enlargement of the right side of the heart, this chamber becomes more easy to measure because it dilates in size. So when we're looking at the heart, we have to look at the heart as a baseball. The baseball that is used to play a game most commonly in the US. So when you look at a baseball, like this one here, this is a baseball. So when we cut this baseball longitudinally, we're imagining that it's a heart. So we're cutting the heart longitudinally, and the top part is removed. So what you see is the structure of the heart on the left side, which shows that the right ventricle is actually lying on top of the left ventricle. On the left side, there's an ultrasound image, this one, which is showing a parasternal long axis view of the heart, and also it is depicting that the right ventricle is lying on the top of the left ventricle, and also it is showing the size of the right ventricular wall, which is thinner than the ventricular muscle. So this is the wall of the right ventricle, which looks thinner as compared to the wall of the left ventricle, which is lying at the bottom. For reasons, obvious reasons which I've mentioned, is that the right ventricle only pumps blood to the lungs. Therefore, the thickness of the heart muscle is not compared to the left ventricle, which has to pump blood to the rest of the body. So the left ventricle requires more force. Therefore, it has a thicker muscle. We see that there are actually valves. There's a mitral valve here, there's an aortic valve, there's also a right ventricular chamber seen in this image. So when we are looking at the right side of the heart, we should also look at not only the structure, we also look at the function, what we call the physiology. What is going on in there? What are the hemodynamics? So we usually look at the pressure. The pressures, the feeling pressures on the right side of the heart, because normal feeling pressures will allow the right side of the heart to function without any problem. Increased feeling pressures will make the right ventricle dysfunction and therefore fail to contribute to the normal function of the heart. So we'll look at the hemodynamics with echocardiography. That means we are going to measure the pressure gradients across the tricuspid valve, because the pressure gradient between the right ventricle and the right atrium actually gives us a story. It tells us the pressure between these two chambers. So we also look at what we call the pulmonary resistance, vascular resistance, because the more resistance is there in the pulmonary vasculature or vascular bed, the more the pressure on the right side will actually rise. So when we are looking at the right side of the heart, we should also look at the physiology. How does the right ventricle and the right atrium function? What is the behavior? So inside there are hemodynamics, which are supposed to be measured to know the pressure gradients across the valves, and also the final pressure in the pulmonary circulation. Because what actually defines pulmonary hypertension is raised blood pressure, pressure on the right side, more than the normal values. So also we look at the pulmonary vascular resistance. That is the resistance that is encountered at the pulmonary capillary beds. Because the higher the resistance, the more pressure actually will be encountered. We also look at the mean pulmonary arterial pressure. All those are pressures that are supposed to be considered when we are imaging the right side of the heart. We're also looking at the diastolic pulmonary arterial pressure. That means the pressure of the pulmonary artery in a situation where the heart is not contracted. So all those parameters are supposed to be evaluated. Actually, in this image, it is showing that we are measuring the pressures on the right side of the heart. We are using what we call a catheter that is inserted through the superior vena cava, that is the vessel that brings blood from the top part of the body into the right side of the heart. So a catheter is inserted in the lab to measure pressures from the right atrium through the tricuspid valve, the difference in pressures as the catheter is moving, up to the time the catheter, as depicted on this image, it moves from the superior vena cava into the right side of the heart, and from the right ventricle it goes into the pulmonary artery until it wedges into the distal portion of the pulmonary artery. So as the catheter, what we call cardiac catheterization, as the catheter is moving, it is also measuring the pressures in the chambers during contraction of the right side of the heart and during relaxation. So as the catheter is moving, the values are being recorded. So if we find higher values, we know that this situation is a situation of raised feeling pressures on the right side of the heart. So what is the definition of pulmonary hypertension? Pulmonary hypertension is mean pulmonary arterial pressure of more than 25 millimeters of mercury, more than or equal to 25 millimeters of mercury, as measured by an invasive method which we call cardiac catheterization. In this case, right heart catheterization. So we cannot measure the arterial pressure, feeling pressures on the right side of the heart without getting a better conclusion if we don't use a catheter. We can do just an assessment, an estimation using an ultrasound machine, but the gold standard for measuring the pressures on the right side of the heart is what we call cardiac catheterization, which is done in the lab. So this is just a picture which shows the procedure which is done in the cath lab, in which they insert a catheter through the inferior vena cava into the right atrium, and finally through the tricuspid valve, and finally into the right ventricle, and proceeding towards the pulmonary circulation. So this is a procedure that is done in the lab to get the true pressures on the right side of the heart, so that we can conclude that whether a client or a patient has got pulmonary hypertension. So what are the causes? The causes of pulmonary hypertension, pulmonary arterial hypertension, post-capillary pulmonary hypertension, they are quite vast. In this presentation, we are going to dwell much on causes that arise mainly as a problem of the left side of the heart, and also some that arise as a problem of the right side of the heart. So in this case, there are what we call thromboembolic events. That means a thrombus, that is a clot, has formed in the pulmonary trunk. So once the clot has formed in the pulmonary trunk, it will cause raised feeling pressures on the right side of the heart, which qualifies to be defined as pulmonary hypertension. Another cause is patients who have got chronic hemolytic anemia. They are prone to develop pulmonary hypertension. The other cause can be what we call idiopathic. Some of the causes of certain diseases cannot be identified or cannot be found. You do all the investigations, but you come out with no clue or no answer what is causing the pressure to be high on the left side. So that one, where there is no cause, we call it idiopathic. The cause is not known. The other causes can be congenital or hereditary. So the disease, sometimes it runs in certain families. So we also have to look at the families and screen them to see whether there is any family history of pulmonary hypertension. Drugs and toxins, there are certain drugs and toxins that can cause the left ventricle to malfunction and therefore create a conducive and atmosphere environment for pulmonary hypertension to occur. Liver cirrhosis. On this image, there's an image of a liver which doesn't look good. It's a diseased liver, and that's a liver. We call this liver cirrhosis. That means the cells of the liver, they have been damaged. Therefore, they've been replaced by fat or scar tissue, and therefore causes the liver not to function properly. And that one can also cause problems of the right side of the heart, which we call pulmonary hypertension. There's also chronic obstructive airway disease or pulmonary disease. Diseases that cause obstruction to the airway can be congenital, they can be acquired. They can also cause the problem of the right side of the heart. leading to pulmonary hypertension. Interstitial lung disease, diseases that affect the alveoli, the cells of the lungs, can also cause pulmonary hypertension. Sleep apnea, people have got sleep disorders. There are also some cases that have been discovered that they develop over time, they develop pulmonary hypertension. And also those people who go on high altitude, we know that the higher we go, the lesser oxygen concentration. So where there's lesser oxygen concentration, there will be lesser perfusion to the lungs and other tissues, including the heart itself. Therefore, that can cause, in some cases, the right side of the heart to dysfunction or to fail to function. Once it fails, that means there will be a lot of pressure overload on the right side of the heart. When there's pressure overload, it tells us that feeding pressures are high. This is a specimen of a client who had, as one of the causes, CTEPH is chronic thromboembolic pulmonary hypertension. What happens? A thrombus formed in the pulmonary trunk and caused obstruction. Where there's obstruction, there's a tendency to have high pressures developing. So in this case, this patient had a thrombus which was extracted, as seen on this image. It was extracted from the pulmonary trunk. That was the cause of the symptoms of pulmonary hypertension. In this image, it's just an MRI on the right, showing the thrombus lodged. The thrombus is lodged here. On this image, it is lodged actually in the pulmonary trunk. This is the pulmonary trunk. So this is a clot here which had lodged in there and caused the obstruction, and that obstruction causes high feeding pressures on the right side of the heart. This is another image of a bronchogram where they show that where the thrombus had lodged, there is no air going to the portion of the lung because there was an obstruction here due to the thrombus, and there's no perfusion. Actually, there's no perfusion. No blood is going to this portion. So this bronchogram combined with an angiogram of the pulmonary trunk, it is showing that here is cut off. This is the left pulmonary artery, and this is the right one, which is showing that on the right things are okay, but on the left there's an obstruction and there's poor flow of blood because of the thrombus. And that was relieved by an operation where they removed the clot, which they call thrombectomy, removal of the thrombus or the clot. In these days of HIV infection, this is a structure of an HIV virus. The virus can cause a lot of problems. It has no respect for any organ. It can cause the dysfunction of the muscle of the right side of the heart, causing myocarditis, which can cause poor function of the right ventricle. This is a clip of a congenital cause of pulmonary hypertension. This patient had congenital heart disease. Congenital heart disease is a disease that the patient is born with. From the time the baby is born, the heart disease is present. It can either be a hole in the wall of that separates the top chambers, the right ventricle and the left ventricle. So there can be a hole there. So when there's that hole, that means blood will be shunting from one ventricle to another. In this case, it will be shunting from the left ventricle once it pumps into the right ventricle. So what happens? Blood from the left ventricle into the right ventricle, causing high pressures on the right side, and that can cause the ventricle, the right side of the heart, to enlarge because of pressure overload. It can also be a hole between the bottom chambers, that is the atria, not the ventricles. So the left atria and the right atria. There can be a hole, which we call an atrioseptal defect. So there's a defect in the septum. The septum is just a wall that separates the two chambers. So it can either be a ventricular septal defect, which is a defect between the two ventricles, or a hole. So that one can cause high filling pressures with time and cause pulmonary hypertension. Like in this case, we can see that blood actually is moving from one chamber to another because there's a hole. There's actually a hole here where we see the blue flow or turbulent flow from one chamber to another, and also here, which is showing flow from the left ventricle to the right ventricle through the VSD, or ventricular septal defect. So that one can cause pulmonary hypertension. So it can be a congenital cause as well. Whatever is causing the problem of the right side of the heart, what is common is that they all end up contributing to the cause of what we call pulmonary hypertension. And pulmonary hypertension, as I briefly defined it, it's an increase in right side systolic pressure or mean pulmonary arterial pressure of more or equal to 25 millimeters of mercury, because the normal is supposed to be between 18 millimeters of mercury to 25 millimeters of mercury, as measured invasively by right heart catheterization, which I've actually explained. The epidemiology of pulmonary hypertension, 78% of the causes of pulmonary hypertension is due to problems of the left side. Could be valve problems, malfunction of the left ventricle, the dilatation of the chambers causing high pressures on the left side, which causes a backup or a backflow to the pulmonary circulation and translated to the right side of the heart, causing pulmonary hypertension. So I've mentioned the lung disease, I've mentioned also chronic thromboembolic phenomena, and I've mentioned also pulmonary arterial hypertension, which is mostly to do with the problems of the lungs as a contributor to pulmonary hypertension due to pulmonary vascular resistance. So this is another clip. I'll freeze it. In this clip, it is showing that the chamber, the right side of the heart is obviously very enlarged, because we see that here, this is the right atrium, the chamber that actually receives blood from the top part of the body and the bottom part of it. The blood that has been used by the body now is returning to the heart. So this chamber is enlarged here. Why is it enlarged? Wherever there's enlargement of a chamber, there's an overload or volume overload. So what is causing the volume overload should be a problem of either the valve of between the right ventricle and the right atrium, or between, it could be a problem arising from the left side of the heart. So in this movie here, we are seeing that this one is the right side, and at the bottom is the left side of the heart. You can see how dwarfed the left side of the heart has become, because the right side of the heart is actually very enlarged. And we also see that the tricuspid regurgitation is very severe. That means the backflow of blood between the two chambers, the right ventricle and the right atrium, is severe. There's a high velocity showing a high continuous Doppler tracing. So when there's high pressure, high right ventricular systolic pressure, we should look at the tricuspid valve. We know that tricuspid valve, even in normal subjects, there's just a little bit minimal or trivial regurgitation. That means trickling back of the blood once the chambers contract. But in this case, it is exaggerated. So that one can give us a good measure of the pressure between the right ventricle and right atrium. So we can see that in this case, it is actually high. It is more than 5 meters per second. So when we use our Bernoulli equation, which says that 4 multiplied by velocity squared will give us the pressure gradient between the two chambers, the right ventricle and the right atrium. This is another tracing here, which is a Doppler, tissue Doppler, which is showing how the right ventricular muscle or the myocardium is relaxing and contracting. And we are seeing that actually there's poor relaxation. So there's actually very poor right ventricular function. This is a case where there's right heart failure, because the right heart has failed to perform, to contract and circulate blood effectively due to one cause or another. There's another slide here which is showing different grades of dilatation of the right side of the heart. This is the left, that's the right, and on top there's also one thing we are seeing in this slide, that the patient had also pericardial effusion. So this echo-free zone you see here, it is fluid around the heart. So pericardial effusion in pulmonary hypertension is a very poor prognostic indicator. That means the prognosis or the outcome of this disease is poor once the client presents with pericardial effusion. The other thing we are noting from these images is the shape of the left ventricle. The left ventricle here, this is fluid I was talking about. Now there's a flattening of the ventricular septum. Why is it flattening? Because there's high pressure here in the right ventricle. So once there's high pressure here, it pushes the septum down, and therefore the ventricle assumes what we call a D-shaped ventricle because of severe pulmonary hypertension. The other thing to note here in this image at the bottom is that we are seeing that here the closing of the tricuspid valve is poor because the heart here is dilated, there is stretching. So here we expect that there will be a lot of tricuspid regurgitation. Tricuspid regurgitation causes right atrial pressure overload or volume overload. Therefore, the volume overload causes a poor right ventricular function, and that causes worsens the pulmonary hypertension. This is another slide. As I was mentioning, there's pericardial effusion. Pericardial effusion in severe pulmonary hypertension or right-sided heart failure is not actually due to maybe something else which is not familiar. It is actually just due to lymphatic derangement. That means dysfunction of the lymphatic system causing accumulation of fluid in the pericardial space. And this fluid should be left alone because it has been seen that it's detrimental to the patient if an attempt to tap the fluid is made. So that fluid is just due to lymphatic derangement, so it should be left alone because some patients have deteriorated after tapping the same fluid. This slide here is showing the estimation, as I mentioned before, the estimation of right ventricular systolic pressure. We should take into account tricuspid regurgitation. Where there is no tricuspid regurgitation, it's very difficult to measure or to assess pulmonary hypertension because we'll not be able to get the measurements for right ventricular systolic pressure. So there must be at least some tricuspid regurgitation. That is the backflow between the right ventricle and the right atrium. So the normal tricuspid regurgitation, which I mentioned that in some subjects it is actually normal. It's supposed to be, the velocity should be between 1.7 and 2.3 meters per second. Once the figures are higher, when we use our Bernoulli equation, we're going to find that this client will qualify to have moderate to severe pulmonary hypertension. And the formula is right here at the bottom, where this is the Bernoulli equation. The 4 is multiplied by the velocity squared, and the figure that we get, we add an estimate of right atrial pressure. And that right atrial pressure can be estimated from the size of the inferior vena cava, because once you see an inferior vena cava is dilated and is not collapsing, it's supposed to collapse 50% with every breath. Now, if it doesn't collapse, that means the right ventricular systolic pressure or arterial pressure is more than 15, because the normal right atrial pressure is supposed to be somewhere between 10 and 15 millimeters of mercury. So once you see a dilated inferior vena cava which is not collapsing, just know that the right-sided filling pressures are high. Like in this case, this client actually had very high right-sided filling pressures, because we know this is the inferior vena cava. In the short axis view, we see dilated hepatic veins, because this is liver and this is inferior vena cava, dilated hepatic veins. And when measured in the longitudinal view, when we measure the IVC, we see that it was actually somewhere 3.8 centimeters, which is elevated or dilated. So that one, when we are calculating right ventricular systolic pressure, the size of the inferior vena cava should be taken into account. So in this slide, it's just a grading of various grades of tricuspid regurgitation using our continuous wave Doppler profile. There's one on the right, on the left, and different grades. Whatever the grade, when you measure the velocity and multiply using the Bernoulli equation, you get your estimated right ventricular systolic pressure. So we need to remember the Bernoulli equation, which I mentioned in the other videos, that is a complex equation, but a simplified version for cardiologists has been devised so that we can calculate pressure gradients across the valves. So the other measure is we need to measure the function of the right ventricle by using what we call the tricuspid annular plane systolic excursion, how the annulus or the valve ring of the tricuspid valve is moving during each contraction and relaxation. So if we find a lower figure, we know that the contraction is reduced due to problems of the function of the right ventricle. So if the function of the right ventricle is poor, in a case where someone has got right heart failure, we know that we can talk about right heart failure without talking about pulmonary hypertension. So it's also another measure, as we can see in the graph there. So we can get these measurements and compare. 20 to 23 millimeters, that is mild. That means the movement is okay. But going downwards to about less than 15 millimeters, we know that the muscle of the right ventricle is poor. It cannot generate enough contractility to maintain good right ventricular function. So this is a case from our own practice here. This case, she was a 50-year-old female who had no history of heart disease, was brought to us with progressive history of having shortness of breath. She had swelling of the legs. The X-ray showed an enlargement of the cardiac shadow. The symptoms were worsening, and she was being treated for TB. So after TB treatment for 2 months, the symptoms were just now getting worse and worse. An echo was not done. So when we did an echo, this is what we saw. So we saw, this is an image which shows that the right side of the heart. This is the right side of the heart. We see that this is an atrium. The right atrium is very much dilated and filled up with regurgitant blood. That means backflow from the right ventricle coming back to the left ventricle, because here tricuspid valve is dysfunctional, you see, incompetent. So there's a lot of pressure and volume overload. So we saw actually the dilated right side of the heart. And in another image, when we measured the pressure gradient by the tricuspid regurgitation velocity, we saw that it was actually very high filling pressures on the right side of the heart. And on the image above, we can see that the chambers are dilated. So this is another image just showing how much backflow regurgitation is filling the whole chamber. That means the valve is actually incompetent, the tricuspid valve, causing pulmonary hypertension. So this client as well had pleural effusion, so she had backed up fluid in the lungs. So she was in heart failure and had backed up fluid in the lungs, and she was in severe heart failure. So another message that we should put is that each patient who comes with a big heart on an X-ray should be followed up with a detailed echo exam, because an X-ray, as I said in previous videos, just an image of a chest X-ray will not tell you a story about what is going on in the heart unless you put a probe on the chest, look at the valves, look at the chambers, look at the heart muscle, look at any fluid around the heart. So you come out with an etiology or a cause of what is causing that patient's symptoms. So this is the same image of the same client who had dilated inferior vena cava, which was actually measuring 3.5 centimeters. It was actually dilated. We can see this is a longitudinal view. When we measured, it was dilated because there is problem of right side heart failure. So that's how we manage these cases with problems of the heart being big on an X-ray. We follow up with an echo. We go to another case, 80-year-old patient. She had chronic obstructive lung pulmonary disease. She also had heart failure symptoms. The provisional diagnosis, what they were thinking about was that the patient had hypertensive heart disease and she was on medication, but she continued deteriorating, symptoms escalating. So when she was sent for an echo, we saw a lot of obvious signs of right side being failing, because the right side of the heart, we can see that right ventricle, right atrium is dilated. On both views of the echo windows, it showed dilatation of the right side of the heart. She also had dilated inferior vena cava, which I've already talked about. That is a marker or a sign that something is wrong on the filling pressures on the right side of the heart. So this is a continuous wave Doppler, which is also showing that it's actually very high. There's a lot of tricuspid regurgitation due to poor closing or stretched tricuspid valve ring. This is a Doppler profile on the right ventricle lateral annulus, showing how good is the muscle relaxing, anti-contracting. There was poor diastolic and systolic function, so causing right heart failure in causing the patient's symptoms. The other thing is to the dilated trunk, pulmonary trunk. As I mentioned, if there are high pressures on the right atrium, there will also be high pressures on the right ventricle, which will be translated into the pulmonary artery going to the lungs. In this case, this is a dilated pulmonary trunk. This is the aorta. The distance of the aorta as compared to the distance of the pulmonary artery are supposed to be the same, but in this case we see that the pulmonary artery is dilated. This is a bifurcation, or where the branching between from the main pulmonary artery to the right and left and right, they are both dilated. So that's a clear classical case of pulmonary hypertension. So with echo, we're able to see a lot of things other than we're just looking on an X-ray, which has a big heart, and symptoms of the patient. So just from an echo, we're able to identify a lot of things about this client of ours. So echo still remains a gold standard in the investigation, follow-up of patients with problems of the right side of the heart. So this is the ventricle. Well, the ventricle really doesn't get much problems because it's not involved in certain cases where maybe the problem of pulmonary hypertension is the valve, the tricuspid valve. The left side of the heart will remain functional a little bit, but with time it also fail, because both sides actually, whatever happens on the other side, it will eventually go to the other side. So in conclusion, we know that echo still remains a gold standard and an excellent tool in the diagnosis, evaluation, and follow-up of patients who have got right heart disease. Without echo, you cannot actually know what is going on in there. But with echo, we are provided with the ability to see at the function of the right side of the heart, the right ventricle, right atrium, the pulmonary valve, pulmonic valve, and also we are given with an excellent opportunity to come out with what could be the causes of this pulmonary hypertension and how possible that this patient's prognosis will be good, because we'll see other things like complications like pleural effusions, we see pericardial effusions. We all know that this is an advanced case of right side heart disease or an advanced or severe pulmonary hypertension. So in this video, we just wanted to show that the right side of the heart is equally important like the left side of the heart, where most clinicians would want to concentrate about what happens on the left, ignoring that things can also affect the patient that come from the right side of the heart. Because if there are two hearts, right and left, they are related. There's no way we can ignore the other part. So equally evaluate the left and right with all the steps, with all the energy and the concentration to come out with a conclusion about the way forward to help our client. So for today, we have ended here. We shall continue producing more lectures and demonstrations of cases, especially that we see that actually are present in our environment. We want to thank everyone who has had time to watch this educative lecture.